Thank you for joining us. I would like to welcome everyone to the STS 2026 webinar series. Today's webinar is titled Defining Success in Surgical Treatment of AFib, Updates and New Insights. And this webinar is supported by AtriCure. At this time, I'm pleased to introduce our moderators for this evening, Drs. Bowdish and Dr. Subramanyan. Dr. Subramanyan, let me turn it over to you.
Thank you, Karen. Hello, everybody. It is my absolute pleasure to welcome you to today's STS webinar series. I'm Ram Subramanyan. I am the Chief of Congenital Heart Surgery here at Children's Nebraska, but really today I'm privileged to welcome you in my role as the Chair of the Council on Research and Quality for the Society of Thoracic Surgeons. Today's webinar series, we're going to discuss defining success in the surgical treatment of atrial fibrillation, updates and new insights. We have 4 fantastic talks, and I really encourage you to participate actively. There's a Q&A where we'd love to hear your questions, and we'd like to get as many of them as possible. I hope this will be an educational experience for all of you, and I really want to thank our industry sponsors, AtriCure, for making this evening possible today. Joining me moderating today is Dr. Michael Bowdish. Mike Bowdish is the chair of our Workforce on Adult Cardiac Surgery database, a known STS adult cardiac surgery leader, a dear friend, and is going to help moderate the session moving forward. Mike, take it away.
Thanks, Ram. Thanks for that introduction and those kind words. I'd like to welcome I'm co-moderating this with Dr. Subramanyan, and we're joined by Dr. McCarthy, Doctors McCarthy, Kankui, and Mehaffey. And I thought, I guess Ram introduced me. I'm a adult cardiac surgeon. Ram and I trained together, so we've known each other a very long time. I do adult cardiac surgery. I'm the vice chair of the Department of Cardiac Surgery at Cedars-Sinai in Los Angeles. And as Ram said, I'm the chair of the Workforce on the Adult Cardiac Surgery database. Have everybody introduce themselves real quickly. Dr. McCarthy.
Pat McCarthy, a cardiac surgeon at Northwestern.
Hunter Mehaffey, cardiac surgeon at West Virginia University.
You are still muted, Armin.
Armin Kiankui, cardiac surgeon at Cedars-Sinai, Huntington Health in Pasadena, California.
So we're joined by 3 experts, or 4 experts, I guess, if I include myself, and a congenital heart surgeon in the field of adult cardiac surgery, and specifically atrial fibrillation surgery, with different emphasis. Dr. McCarthy is going to start us off tonight, followed by Dr. Mehaffey, and then Dr. Kankui. Dr. McCarthy is going to give us a big overview of atrial fibrillation. Hunter's going to focus a little bit more on some outcomes aspects of it, and Dr. Kankui will speak a little bit on some technical aspects of the specifically standalone atrial fibrillation. And then I'm going to talk about our new AFib metric, and then we'll have a panel. So with that, I'm going to turn it over to Dr. McCarthy for the next 10 minutes or so, and we look forward to a robust discussion at the end of the presentations.
Thanks, Mike. Let me just check, are my slides showing?
Yes, they are.
Okay, great. Well, it's a real pleasure to be here and to talk about this. This is an area of interest of mine for many decades, since Jim Cox and I worked together years ago on this. These are my disclosures, but what I really want to address tonight, and what we all hope that we get the point across, is that atrial fibrillation is undertreated with concomitant surgery. This is a paper that we wrote several years ago. This is specifically Medicare patients, so the older population. But on the left, the graph is showing that it's very common before surgery. So coronary bypass patients in the Medicare population, about 20% had AFib before surgery, with a variety of other operations, mostly with the mitral operations, very common. About 60% of patients had atrial fib, more than you see with the STS database that includes younger patients. The big issue, though, that we want to address tonight is on the far right. and that the number of patients that had ablation that had pre-op atrial fib is too low. If you look at all surgeries, it was less than 25%. If you look at the non-mitral, the CABG, AVR group, that group was about 15%. Mitral surgeries are always consistently the highest, but even in that Medicare population, it was just over 35%. So we have a long way to go to meet the metrics that you're going to be hearing about in a little bit from Dr. Bowdish. We recently published this. I think it just came out about a month ago. It was presented at the STS. And what we're showing here is that we're doing a better job of treating atrial fib, but again, we still have a long way to go. The line in the middle that is gray is dropping, which is great, and that's the group that had no atrial fib treatment. But still about 25% of patients had no AFib treatment. What's changed over time is that there's more left atrial appendage treatment, but the two top lines are basically flat at about 45%. We're not doing enough surgical ablation. Left atrial appendage is great for decreasing strokes. It doesn't treat the entire disease, though. When you look at it more deeply, there's also some pretty surprising statistics here. If you look at the no AF treatment up on the top left, there's a whole lot of people, 291, that were less than 5%, so virtually no treatment of patients with atrial fib. And then a whole lot of them where it's like 25% or less. So we really need to do a better job with this. On the far right, if you look at the group that have the optimal treatment, which is surgical ablation with closure of the left atrial appendage, look on the far right, there's a very small number where it's 80% or more. So again, lots of patients aren't getting treated, and it's highly variable by surgeon. It's also variable by region in the paper when you look at it. There's some regions that are much more aggressive and others that are not. So basically, why should we do this? I'm going to be brief because there's so much information about this, but the benefits are three: survival, stroke, and heart failure. The risks are manageable. It's pacemaker and renal dysfunction. So there's so many papers about improving late survival. This is just some of the US studies, and I can't put them all together here. There's others outside the US. One of the first from the top left there was at Northwestern. That was our group. And what we showed in red are the patients that had AFib untreated. Their survival was worse than the patients that had it treated, and their survival was equivalent to patients that underwent surgery that had no history of atrial fib. The one next to it is the same for paroxysmal atrial fib. The paroxysmal atrial fib patients also have better survival with that, but others have shown that, WashU has shown that, and others, and in coronary bypass. Again, there's so much data on this now that I couldn't go through it all. This is another part that you can't get from the databases, but when we looked at it at Northwestern, the survival was better if you had a successful AFib treatment. So that speaks to you want to do enough surgery to get the best possible result, freedom from atrial fib. Now let's turn to the left atrial appendage. This is one of the most studied operations in all of cardiac surgery. On the left are some registry data that had been performed before, showing that if you did left atrial appendage occlusion, it improved stroke and mortality. But the one on the right is the LEOS 3 trial, published in the New England Journal of Medicine, 2021. This was about 4,000 patients, as I recall, and at 3.8 years later, there was a 33% relative reduction in stroke. That's pretty amazing for this group. And if you look at that blue line, the occlusion it is relatively flat. So once you've occluded the appendage, they don't just keep going up year over year like the no occlusion group as well. That was a really landmark paper in cardiac surgery, and it really has informed everything that we do, and part of the reason that we're here tonight. So I'm going to show you how I approach this with a mitral operation. Step one is to close the left atrial appendage. You put the clamp on, you open the left atrium, and after the cardioplegia is in, it literally takes less than 90 seconds to lift the heart, put the clip on, cut the sutures, remove it, whichever type of clip that you use. There's two commercially available now. There's a third that was just approved. There'll be more coming, so there's a lot of different choices for this. Bottom right is showing the effectiveness of a clip. In one device, newer data is 98.4% effective. It works really well. The bottom left one is important. The red area are showing that appendage, it becomes necrotic and therefore electrically isolated. So if you do a clip, you don't necessarily have to do that ablation line into the appendage. That saves you a little time. So on the top left is how I used to do the cut and sew. That's the Cox-Maze 3, where I excise the left atrial appendage. But on the top right, the drawing is showing how we do it now. It's just 3 separate ablations, 8 minutes of cryoablation. Surgeons have a very low threshold for things that take too long. And so we want to move this along. And so it's 3 separate cryoablations. The box lesion that also you bend the probe, it goes to the mitral annulus. That's 2 of them. And the bottom right, the video is showing about a 1 to 2 minute on the coronary sinus. So it's all the left atrial lesions of the cryomaze 3. You always watch out whenever you do some type of ablation, whether it's cryo or radiofrequency, you want to mind the gap. Make sure that the lines overlap. The way that operation is set up, there's only one. It's near the base of P2, and it's simple to make sure that they overlap. There's debate about whether you have to do the right side biatrial or if you do just the left side only. A lot of my patients are very early, they're asymptomatic, the right side isn't involved. I do it when I do a tricuspid generally. This is 2 ablations. This is another 6 minutes of ablation to do this. It's quicker and easier to do the right-sided thin-walled right atrium. What is always said about, and it's true about the biatrial, is there's more pacemakers with it. That's for sure. One of the things we need to know is it's not just the SA node at the lateral junction of the SVC in the right atrium. There's the atrial pacemaker complex, and you shouldn't freeze it. You shouldn't cut it. You shouldn't bipolar radiofrequency around that. I think that's important. You'll see why in a little bit. The other is if you do get sinus node dysfunction, like long-standing persistent, wait it out. Pace them at a low rate, about 60, give them 7 days before you put in a pacemaker. Most of them pick up over time. We published this a few years ago. It was presented at AATS. So after we had that data from 2012 on survival, I said, well, why would we not treat atrial fib? So 100% of the patients with mitral surgery had concomitant ablation. With that procedure I just showed you, it added 10.5 minutes of cross-clamp time compared to mitral only, 13 minutes of bypass time, no increase in renal dysfunction, and 0.7% pacemaker rate for a mitral maze. So avoid that atrial pacemaker complex and wait it out if you have sinus node dysfunction. The survival wasn't just the same as patients with no history of atrial fib. It was also matched to CDC population, and this is patients with mitral and AFib disease, so that's pretty amazing. On the right, you'll see the 1-year freedom from atrial fib with a 3-minute freezes was 92%, seems durable over time. 5-year freedom from stroke was high. So one of the things that we think about is how do we make this so that most surgeons can do this and that it's not Cox-Maze 4 or do nothing, which is what the field was taught for many years. So Armin Kiankui had suggested that we have sort of divided into the group where the left atrium is open, like I just showed you with mitral surgery. And on the right is, well, what if you don't open it as a bypass aortic valve and aneurysm or something? And then also, what do you do in things like a reoperation? So I'm not going to go through all of this, but we try to match the ablation to the specifics of the patient in this review that Jim Cox and I wrote a few years ago. But using all the different tools we have, the lesion sets and the goals, then it seems that we should be able to do much better and treat far more patients than we currently do. There's a lot of discussion about biatrial, left atrial, bilateral pulmonary vein isolation, or whatever. Let's look at what the real data shows. So the meta-analysis down at the bottom left is showing sinus rhythm in the meta-analysis. Biatrial, about 76%, left atrial, 71%, a 5% difference. Look at the CTS NET trial, a randomized clinical trial, the biatrial 66%, pulmonary vein isolation 61%. I'm not saying that you should do pulmonary vein isolation. What I'm saying is that there is a difference in effectiveness. It's not huge. And young surgeons, people early in their experience, shouldn't feel they have to push themselves into biatrial. You can step into this as you're learning. There's also some new tools, and there's some interesting information coming out on this. The video's courtesy of Mark Gerdish on the right. So this clamp does bilateral pulmonary vein isolation plus the posterior wall of the left atrium. So it's a single application. You don't have to dissect out the left and then the right-sided pulmonary veins. And it gets all the way to the base of the left atrial appendage. So with this, you're doing all of, theoretically, the left atrial lesions and the clip to the left atrial appendage. The only thing you're missing is the mitral valve. And the data on this so far looks good. It's still early in the experience, but I've seen reports with 1 year, 84% freedom from atrial fib. And this is one that is actually easy to teach to a lot of surgeons. So if you're doing a cornea bypass or an aortic valve, one where you're not open in the left atrium, this is another good option. So we want to do the right thing. You want to decrease the patient's risk for stroke, improve their survival. We also get paid to do it. I'm not obviously going to go through this. Mark Gillenov and I spoke to CMS, and so we are reimbursed for coronary bypass patients, multiple valves. We're going to work on them for mitral valve only, and then also for standalone. So it's great that we're helping patients, and then it was just more recently that I found out we're also getting paid for it, which is great. So what is the state of the art today? It's class 1 for both. The quality metric is 70% surgical ablation with or without the appendage. The left atrial appendage use grew gradually up to almost 88%, but it's 99% for the left IMA, so we still have room to grow. Ablation is flat. You're going to hear from Hunter Mehaffey about why we should be adding ablation and not just doing the left atrial appendage. Lots of surgeons are doing very little of this operation, and only a few surgeons do it in a lot of these patients. And then to set it up for Armin, the EP are pretty obsessed these days with pulse field ablation. It is faster. They can do more cases in a day, but the results are not better. There is still room for us to be working on the more difficult AFib approaches or patients. So the ideal approach, try to treat as many patients as you can, but you want it to be quick. You don't want to be on pump a long time and get renal dysfunction. You want it to be effective, high freedom from atrial fib, and then a complete left atrial appendage occlusion. Sutures sometimes fail pretty commonly. Then no pacemakers that are maze related. If you do a aortic valve with tricuspid and you have heart block, that's a different issue. But also we want to make this very familiar, easy to understand, and really make this easy to do. And it's far better than it used to be 20 years ago. Thank you very much. And then Hunter, I'm going to hand this off to you.
Thank you. Really, really great summary, and folks should be able to see my slides now.
We see it.
Perfect. So, no, really, really great summary, and I'm going to kind of jump into some of the data, some of the longitudinal data, and some of the reasons why we think this is something really important. So we'll start with the guidelines, the 2023 guidelines, clinical practice guidelines for the surgical treatment of atrial fibrillation. As a reminder, this version of the guidelines upgraded surgical ablation concomitantly at mitral valve surgery was already a class 1A recommendation based on the CTS-Sin trial. But these guidelines upgraded left atrial appendage obliteration at the time of cardiac surgery up to class 1A based on the LAOS 3 data that you mentioned that was published between the 2017 guidelines and the 2023 guidelines. And then importantly, the guideline committee rated ablation during other concomitant non-mitral cardiac surgery as class 1 level B non-randomized. And so really highlights the guideline support for not only left atrial appendage obliteration, but also surgical ablation during all cardiac operations in patients.
Dr. Mehaffey, I'm so sorry to interrupt. Can you just speak a little bit louder for the attendees? Thank you.
Yeah, certainly. So the important questions that still remain, does ablation add anything beyond closing the appendage? Is the benefit durable or does it fade after a year? And should paroxysmal AFib be treated or only persistent AFib? And then importantly, which lesion set should we be using? And is it worth adding additional time during a CABG operation? So I'm going to walk through 4 recent papers that we have published that answer a lot of these questions and provide important data based on nearly 200,000 patients. So the first paper will be looking at all patients undergoing cardiac operations and using CMS data, over 100,000 patients, both CABG and valve, with preoperative AFib. The second paper will be looking at patients undergoing isolated CABG, almost 20,000, again, from a CMS data set. And then the third paper will look at mitral valve surgery and look at the differences in patients with paroxysmal versus persistent atrial fibrillation. And finally, the most recent paper that was just published, a analysis of the STS adult cardiac surgery database with CMS linkage, looking at nearly 60,000 isolated CABG patients with a median follow-up of over 6 years. So first, this paper was published in JTCVS a few years ago. And really what we did is took all patients undergoing first-time elective CABG or valve surgery, and we split them into 3 groups. Patients who underwent a surgical ablation of any type with left atrial appendage obliteration, those that underwent left atrial appendage obliteration alone, and those that received no AFib treatment. Now, importantly, compared to those who received no AFib treatment, those who underwent surgical ablation with clip placement had a 32% improvement in their 3-year mortality. Furthermore, even when comparing surgical ablation with appendage obliteration versus appendage obliteration alone, there was still a 10% reduction in 3-year mortality. So adding surgical ablation is beneficial above and beyond ligating the appendage. Second study we'll talk about is those isolated CABG patients. And similarly, we split patients into the same 3 groups and demonstrated that, again, surgical ablation with appendage obliteration was associated with significant reduction in stroke or mortality over a 3-year time horizon. Interestingly, the dates of this study period started back in 2018. And so we actually saw a much lower rate of AFib treatment in general, with 59% of patients undergoing isolated CABG receiving no concomitant treatment for the AFib, not a not dealing with the appendage or an ablation. Importantly, Dr. McCarthy's data that he showed, the publication that he and Dr. Hodges recently presented, show that actually since 2018 we have made a remarkable improvement in treatment, but that's predominantly been with appendage ligation. And then finally, we asked the question, in patients undergoing mitral valve surgery, is there a difference in the relative benefit of adding surgical ablation if the patient has persistent versus paroxysmal AFib? And what we found, again, in the CMS data set, over a 3-year horizon, is that patients received a similar benefit to surgical ablation with left atrial appendage obliteration compared to no AFib treatment or just obliterating the appendage. You can see here on the left, the persistent lines, ligating the appendage really was no different than doing nothing from a survival standpoint. Similarly, in the paroxysmals over here on the right side, we see a similar reduction in stroke and mortality with the combination of both ablation and appendage obliteration. So rhythm chronicity should not gate the treatment, and paroxysmal AFib benefits as well. Finally, I wanted to talk about the most recent publication, this STS-linked analysis, in which we looked at all isolated CABG patients with pre-op AFib over a 12-year horizon. And what we demonstrate is significant mortality benefit with surgical ablation. Interestingly, when we divide surgical ablation into epicardial versus intracardiac, we see that the intracardiac ablations were associated with a higher perioperative risk. However, these lines crossed at 2 years, and beyond 2 years, the patients see the same mortality benefit. Again, left atrial appendage obliteration, we saw a stroke benefit, but no survival benefit. And so I think what this paper really kind of cements is, over a much longer horizon with very robust risk adjustment using the clinical database, we're able to start to sort out some of the survival differences between AFib treatment. So in summary, 4 consistent signals across nearly 200,000 patients. First, close the appendage in everyone. It significantly reduces the risk of stroke. Number 2, add ablation for the survival benefit. Number 3, regardless of the chronicity of the AFib, treat the AFib. And surgical ablation is treatment of the AFib. And finally, the benefit is durable over a long time horizon. And so the bottom line is, across all 4 of these studies, the direction never reverses. Concomitant surgical ablation is consistently associated with longer survival. And then the final question is, well, how much ablation? And I think Armin's going to talk a little bit more about this, but I wanted to show some recent work looking at the Encompass clamp, the left atrial box RF clamp that Dr. McCarthy presented. This is a paper, a multi-institutional study that I worked on with Armin, and what we demonstrated is in patients undergoing non-atriotomy surgery, so patients undergoing CABG and aortic valve, that again, a majority of these patients were paroxysmal. However, at a 1-year time horizon, the freedom from AFib and antiarrhythmic drugs was over 90%. So in patients undergoing non-atriotomy surgery, this may be a really good option, but we need more data. And so I encourage you to follow the patients, track them over time, get Holter monitors, and help us to understand the long-term benefit of this new device. Because biatrial Cox-Maze we have been doing for a very long time. On the right side here, I present our 10-year series of biatrial Cox-Maze in patients with persistent or long-standing persistent atrial fibrillation. And you can see the results are outstanding. Over 90% freedom from AFib and antiarrhythmic drugs over a 5-year time horizon. So it's really important to get the data to continue to understand these new devices and help determine how much ablation is indicated for each of these groups. So in closing, ligate the appendage at a minimum, add ablation anytime it's feasible, don't gate AFib treatment on AFib type. Epicardial ablation may be favorable during coronary bypass grafting. Tailor the treatment to the patient's life expectancy. And we have to improve overall rates of treatment. And I think as a point that we're going to cover later on in the webinar, quality metric certainly helped us do that for left internal mammary use. So perhaps it can do the same for AFib management. With that, I will hand it over to Dr. Kiankui.
Thanks so much, Dr. Mehaffey. Excellent talk, as always. I always learn something new when I hear from you. Let me share my slides here. Okay, everyone see my slides okay?
Yes, we're good to go.
Okay, great. So we're going to change gears a little bit here. We're going to define success in the surgical treatment of AFib, new updates and insights, but in the standalone AFib population. And so if we look at this population, or here are my disclosures. So if you look at this population or this approach in standalone AFib, this is original data published by Dr. Ad looking at standalone AFib treatment in North America, published in 2020, and that group went back and looked at data from 2012 forward, and you can see it was slightly growing, but pretty stagnant. But what was important is that they showed that the majority, even up to 90% almost in 2016, that standalone procedures were done off pump, and that's what this blue line depicts here. And then Dr. Bowdish and colleagues then recently published in the new update that really, if you were to take this and then overlap it to 2016, the treatment of standalone AFib by surgeons has increased dramatically. It's doubled into the most recent data point, so quite encouraging. Now, when you define success in this patient population, it is somewhat different than in patients who are undergoing concomitant surgery, because this is the only reason that they're coming to the operating room. They have standalone AFib. It's often very symptomatic. They're on medications for it. They're on anticoagulation for it. And so when you think about success from a patient-centered point of view, you can assess it actually quite easily. Years ago, we did a study where we asked patients before their standalone procedure to fill out an affect questionnaire, which is an AFib quality of life questionnaire. And then we had them fill out this questionnaire after surgery, a year after surgery. And what we learned from the patient is that they improved their quality of life mostly because they were able to alleviate their treatment concerns. And what that means in that subscale of that questionnaire, what that means is they were able to be relieved from medication side effects like antiarrhythmics and oral anticoagulants. Of course, other things were important to patients too, like improvements in daily activity and their treatment satisfaction and their symptoms, but it was very much driven by the medications. So as a surgeon, if you're trying to define success within that kind of context of the patient, what you're trying to do is get patients off antiarrhythmics. What you're trying to do is get them off oral anticoagulants. And what you're trying to do is do that because you perform a technically perfect operation. And the other thing that's unique to the standalone population is that our approach really is compared to what our EP colleagues are doing. And what's most important to them, to us, to our patients in this space is really the safety of the approach. Our EP colleagues have excellent devices that provide ablation with minimal complications. And we really owe it to our patients and our referral base to maintain that minimal complication rate. Really, we have to talk about less than 1% major complications. In addition to that, like I said, you have to create a technically perfect left atrial appendage obliteration and prove it with the TEE or CT scan. That's the only way you can even start to have a conversation about what to do with the patient's oral anticoagulation. And then finally, when you talk about antiarrhythmics and getting patients off antiarrhythmics, of course, there needs to be significant freedom from atrial fibrillation. And you can't do that unless you perform a technically perfect surgical ablation and monitor it appropriately. So let's start off with defining a successful left atrial appendage obliteration. What I really like to focus on in folks who are doing minimally invasive left atrial appendage obliteration is identifying landmarks before you obliterate the appendage. So whether you're doing it robotically, mini thoracotomy, or VATS like in this video, what I really like to do is identify landmarks on the appendage. So here's this little fat pad. You can kind of see this line here. There's this little lobe here. So I check the anterior surface. Then I flip up to the posterior surface. Again, okay, I got this lobe here. I have to get under. And I have this little white mark here that absolutely I have to get under that really defines that base. So once I've identified those landmarks, then I go ahead and I'm using a AtriClip Pro Mini here, which really allows me to see nicely. And okay, here we go. Here's that little fat pad. I got under that. Here's the lobe, that little lobe I showed there. Here's that little white mark there. And I really make sure that I've incorporated all these landmarks that I've identified before to make sure that when I obliterate this appendage, I am absolutely at the base of the appendage. And once the clip is deployed, I then go back and I check. I make sure, I can grab it now with graspers because it's occluded already, but I check, okay, there's that little lobe here. There's that white mark there. I saw the fat spot there. And so I'm super happy that I've done exactly what I intended to do. And then on echo, obviously it's confirmed. So here's the pre-op echo. Here's the post-clip echo. Nice smooth contour. There's no flow. The circ is still open. I'm super happy with that. So technically, I know that I've done a perfect left atrial obliteration. And then at least you can start to talk about what do you do with the patient's oral anticoagulation. We all know that currently it's unclear what you can do with oral anticoagulation. It's uncertain in the terms of the American Heart Association after you've obliterated a left atrial appendage in a patient undergoing cardiac surgery. A couple things just to note, though, after any ablation, we haven't talked about that. AHA recommends at least 3 months of oral anticoagulation with a 2A, but again, non-randomized. And then if you're going to have this conversation with the patient, let's say in that 3-month period, you should really consider getting the CAT scan to make sure that there's no device-related thrombus or thrombus related to your closure of any type. And then also know that the ATLAC study is currently enrolling, and this is a randomized control study that is looking at, after successful left atrial appendage ligation, that when patients are randomized to oral anticoagulation or not, what are the outcomes? So that's another study that's led by Dr. Richard Whitlock of the LAUS 3. And just to segue into this, I will direct you towards this paper. This was a sub-study of the LAUS 3 data that looked at, again, these were concomitant patients, so slightly different. But if you looked at the patients who had their left atrial appendage occluded and patients who were on or not on oral anticoagulation, their event rates were actually identical in the study. So again, just a sub-study, but again, more information for us to have as we try to make these shared decisions with the patient. Okay, so now let's define success with respect to the surgical ablation. So again, this is just a VATS approach. What you can see are some ablation lines. And what I have here, I'll rewind the video, is a tool that allows me to pace the heart. So I'm pacing it on the native heart above my ablation line. You can see the heart pacing here. And then what I do is I move it within the box. So on my side of the ablation, so to test my actual ablation. And what you can see, I'm still pacing, but obviously the heart is not pacing at the same rate that it was before. Now the patient has their normal sinus rhythm. I also check the superior vein. You can check the carina. You can check the inferior vein. You can check the box. What I'm saying is when you're doing surgical ablation standalone and you have a beating heart, it behooves us to confirm that our ablations have produced exactly what we intended them to produce, at least acutely, meaning exit block or entrance block. I really encourage people to test their surgical ablation to confirm you have that technical success. Then the next step is really teaming up with your electrophysiologist so that they can prove that you have done what you intended to do. So these are just some videos of left pulmonary vein isolation, and we have here voltage maps from our EPs, and my colleague and I, Dr. Dunnington, we looked at all of our ablations, and we were able to say with certainty, when we do this technique, this is our rate of left pulmonary vein isolation. This is the rate of right pulmonary vein isolation. This is the rate of posterior wall isolation. So not only are we checking intra-op, but then typically these maps are performed 6 weeks post-operatively. So we know that we did electrophysiologically what we intended to do at the time of surgery. And then finally, as Dr. Mehaffey was mentioning, it's really important to monitor your patients, but not just to monitor them, but how you monitor them is very important when you're having these conversations about stopping the antiarrhythmics that are so important to patients. This is a sub-study of the CIRCA-DOSE trial. And in all of these patients, they had ICD, so allowed for continuous monitoring. And they did a really clever study. They went back and they looked at all these ICD tracings, and they simulated what the tracings would reveal if the patient had a 24-hour EKG at 3, 6, and 12 months, a 48-hour EKG at 3, 6, and 12, weekly telephone transmissions, a 7-day continuous at 3, 6, or 12, or 14-day continuous. And what you can see here is the sensitivity drastically improves, obviously, with more monitoring. But what's important is if you're just checking a 24-hour ECG at 3, 6, and 12 months, the sensitivity of that test, according to this sub-study, is only about 16%. You can't possibly have a conversation about antiarrhythmic management if your sensitivity of your monitoring is only this low. So I encourage people that if you're interested in this space, you're treating these patients, you're trying to be an arrhythmia surgeon and provide optimal arrhythmia care for your patients, we should really be using more extensive monitoring, 2 weeks of monitoring at 3, 6, and 12 months. So in summary, from a patient success point of view, for them, it's all about discontinuing oral anticoagulation and antiarrhythmics. From a surgeon's point of view, you have to be meticulous about left atrial appendage obliteration and ablation. And then you need to confirm that you've obliterated the left atrial appendage, and you need to provide appropriate rhythm monitoring so that you can at least start to have the opportunity to have a conversation about shared decision-making so you can stop oral anticoagulation and antiarrhythmics. So again, thank you so much for this opportunity to talk about standalone AFib. I will send it back to Dr. Bowdish.
Great, thanks, Armin. Thanks, everybody. I'm going to see if I can. I'm going to try to give us a couple minutes for discussion. So thank you very much. And thanks for, there's roughly, there's 90 people online. So thank you very much for joining us and staying with us. I'm going to very briefly discuss the new STS quality metric for the surgical treatment of preoperative atrial fibrillation. Based on what you've just heard, I think you should get the sense that there's compelling compelling data that treating atrial fibrillation in people who have atrial fibrillation at the time of cardiac surgery is likely something that we should all strive to do. So the STS has a number of process measures. Actually, we have more than 20 process measures. And just in general, I like to ground people what a process measure is. So the treatment associated with a quality measure, it should be the treatment that we're suggesting should be supported by strong evidence with a causal association to benefit or effectiveness. So I think in this case, there's a vast amount of evidence that suggests that doing something for, and I use the word something, ideally treating atrial fibrillation in people who have atrial fibrillation at the time of heart surgery, not only decreases things like stroke, but actually increases survival. In addition, the measure must be quantifiable. So if you're asking someone to do something, we must be able to quantitate it. And then ideally, the treatment that you're asking people to do should be widely applicable by the vast majority of surgeons, including non-experts. It should be relatively simple. It should be something that that people learn in training, that people can learn later on if they've obviously are some time out of training. That it's not a specialized, super specialized skill that requires, that's on the realm of doing something like, say, a Ross procedure, where only a relatively small number of people actually do that. And I only give that as an example. So those are important things. So no one's really mentioned this, but we have guidelines. We have guidelines from the STS which recommend that if you are having mitral valve surgery and you are having first-time non-emergent operation with atrial fibrillation in the mitral valve, there is a 1A recommendation for surgical ablation. Likewise, if you're having non-mitral valve surgery and have atrial fibrillation, there is a 1B recommendation. And then there's a recommendation for left atrial appendage occlusion with or without ablation as a 1A recommendation for basically anyone who's having cardiac surgery with pre-existing atrial fibrillation. So that's important this is what our societal guidelines from 2023 recommend. There are European guidelines, which I took out in the interest of time, which recommend the same thing. So the rationale for this measure is that the surgical treatment of atrial fibrillation during cardiac surgery is associated with improved long-term outcomes and survival compared to not treating the atrial fibrillation at the time of cardiac surgery. The denominator that we are including in this measure is anyone who's over the age of 18 who's undergoing first-time heart surgery with a history of untreated paroxysmal or persistent atrial fibrillation. So it's very important. These are non-reoperative, first-time heart operations in people with pre-existing atrial fibrillation. And it includes patients undergoing a CABG, an isolated valve repair replacement, one valve repair replacement with or without a CABG, and then a multiple valves with or without a CABG. Basically everything we currently have a current risk model for. The exclusions are minimal. They are previous cardiac surgery, sternotomy or thoracotomy, mediastinal radiation, a previous surgical or percutaneous treatment of the atrial fibrillation, or previous left atrial appendage occlusion via any approach, emergent or salvage procedure, and obviously if you do not have a history of paroxysmal or persistent atrial fibrillation. There's a lot of discussion about what the treatment should be. We decided to set the bar very low. We're just asking people to put a left atrial appendage occlusion device or oversew the left atrial appendage in some way, or do an epicardial or endocardial ablation. So if you only put a clip on the left atrial appendage, you meet the metric. Does that treat the atrial fibrillation? Well, not really. It will decrease the stroke risk. It doesn't treat the atrial fibrillation, and we could debate that. But we wanted this, again, going back to the definition of a quality metric, to be very easy for any heart surgeon to do. So the measure is being reported. I'll show you an example from my own institution. It came out a couple days ago. We are currently reporting overall participant and national average compliances in the quarterly harvest reports. Dr. McCarthy mentioned we had an initial threshold of 70%. We actually decided ultimately to not set an initial threshold, and you'll see why in a second. We want to define what those thresholds are and then be thoughtful about what that threshold should be. The metric will be added to reporting for sites that participate in publicly reporting, and there's currently no star rating for this, and we don't really have an immediate intent to have one. This is my own site. So this is Cedars-Sinai's first atrial fibrillation report. Any of you can go. This literally came out on Monday, I believe. You can go look at your own report. So the top line is, remember, this is a 3-year time period. Any patient who had atrial fibrillation who had an index cardiac procedure, you can see that we had 253 eligible procedures, of which 84.19% received something done for that, either a clip or a ablation. And then you can see the national averages at the median and the mean. So 50th percentile I see is 79.4, and the average is 76.6. And then if you break it down, you can see mitral valve operation, mitral valve any AFib, mitral valve with ablation. So mitral valve any is a mitral valve with a clip or an ablation, or with an occlusion with an ablation. And then specifically mitral valve with a specific ablation. You can see even in our center that's very aggressive with this, 71% had a AFib ablation. Puts us well above the national average, which is only 64%. These are people who have mitral valves, people undergoing mitral valve surgery. Only 64% got an ablation. First time mitral valve surgery. Pretty incredible. So you ask, why don't we have star ratings? Well, because quite honestly, personally, I would give the entire nation 1 star because the national averages are so low, as we've shown in all of this. So the hope is that this metric will bring this to your attention and let you see that these are numbers that we would like to see. So on the bottom, while we provide the red bar, which is the national average, we're not shooting for average here. We're shooting for hopefully see the red bar move to the left, and then obviously see sites averages move to the left. And then when we have what we think is a reasonable, meaningful, national average, then we can consider doing some sort of an actual rating system. So just an example from my own site, what the report looks like. We're going to change some of the language here so it's a little more clear in the next iterations, and also make it clear that we're not, the language on the bottom that says better than expected or toward the left, the expectation is not the national average currently. The national average is in the view of the STS and its leaders is lower than it should be. So there's strong evidence to support treatment of atrial fibrillation at time of first-time cardiac surgery. We are promoting excellence by starting to monitor this and report rates of surgical treatment to us sites during first-time index cardiac operations, and we hope that this will have an impact on our patients by increasing the adoption of these easily applied techniques, which do prevent morbidity and improve survival in patients undergoing heart surgery. With that, we are going to go to a panel. How do we do this? I stopped sharing, correct? And I think once again, we only have 7 minutes. There's one question here. I want to start with I don't know, maybe Dr. McCarthy. The newest STS data suggests the appendage is being increasingly managed, but has plateaued, and much of that increase has been left atrial appendage management. Do you think we're actually doing anything good with that, or are we just using a metric to kind of check a box?
No, I think we're absolutely reducing stroke. So there's no question about that. LEOS 3 showed that even in the group of patients that didn't have surgical ablation, stroke was reduced. I think Hunter's paper with the STS data showing that beyond that, if you add surgical ablation with left atrial appendage, then you have better survival. That's the important message that we also need to get to people. If you, again, look at the LEOS 3 data, if you see the cause of death, it wasn't actually stroke in a lot of them, it was heart failure. And so atrial fib can contribute to heart failure in that group of patients. And so we shouldn't be viewing this as if the only sequelae of atrial fib is stroke and we've treated the appendage, we're done. So
That's great, Pat. Hunter, what do you take for, people who, the least treated patients tend to be the sicker, maybe not so elective. They're not emergent or, salvage, but they're sicker. They're a little higher risk, and people say, "Oh, I'm just going to skip it." What do you think
You
about
have to balance and tailor the treatment to the patient. Without a doubt, that's one of the things I really like about this quality metric, this step in that direction is the bar is very low. I think the goal is not to encourage people to do something they're not comfortable with in a very sick, frail patient, prolong clamp time and do those things. But I think that there is enough evidence now to show that, if you're looking for a survival benefit, again, we're talking a longitudinal survival benefit. Those are not typically your frail prom of 6% cabbage patients, right? So I think if you focus on the patient's disease burden and do something, at least clip the appendage, at least prevent strokes. But if you can also add on surgical ablation, whether it's a non-atriotomy ablation or a full biatrial maze based on the patient.
So that brings me to, it's a great segue to my next question for Dr. Kinkui. So I'll give you paroxysmal atrial fibrillation. It's maybe a little more common is PVI, you touched on it a little bit, but is PVI alone enough? Do you need to do a biatrial Cox? I know we could have a whole seminar on this, but, do you think, what's your take on, what should the average surgeon be doing if they want to do something for the patients with AFib?
Yeah, I mean, I think what Hunter's taught us in all these Medicare STS analyses is the majority of patients who come to the OR with AFib have paroxysmal AFib. And so Dr. McCarthy and Dr. Cox and the people who really started this whole movement decades ago also taught us that paroxysmal AFib is mainly a trigger-based phenomenon that either comes from the pulmonary veins or the back of the left atrium. And so an epicardial procedure or an endocardial procedure, whatever the surgeons are comfortable with, especially in the mitral setting, that isolates the bilateral pulmonary veins and possibly the posterior wall, I think is an awesome operation for paroxysmal AFib. And I think, like Hunter mentioned, our multi-institutional data right now would support that as well.
Yeah, I think people should do what they're comfortable with, what they know how to do, So, Dr. McCarthy, is there anybody you think we shouldn't obliterate the left atrial appendage on?
Yeah, I think there's two that stand out to me. One are reoperations. If you have a patent left IMA and you don't really want to go digging that out to be able to put a clip on it. The second group will be the ones that have a thrombus in the left atrium. And so when the quality metrics get more firmed and so on, those would be two that you would exclude for good reason. I'm sure there's probably a few others, but those are the two that kind of pop to mind. You could still think about, if you open the left atrium, you can still close the left atrial appendage and things, but I don't think that we should necessarily mandate that at this point. It's fine early like now to just say, they're just not going to be counted in the denominator.
So, Ram, can I ask you a question? So, as a congenital heart surgeon, kind of as little bit of an outsider, but an insider from the quality standpoint and performance improvement. I mean, this is what we do every night between 4 and 7 p.m., depending where we have different zip codes, different time zones. But, it's 12 months from now, how do we measure this metric? How do we measure the metric that we're measuring? Yeah.
Yeah, excellent point, Mike. And I think that's the challenge for databases and quality registries. There's an excellent question as well, which Robert Lyons brings up a very good point. No, the only thing worse than no ablation may be a bad ablation. How can we ensure surgeons take their time to perform these procedures well. These are excellent points. That's why I think what we're doing right now is starting with awareness to let people know we're not judging, we're not giving you a quality metric as a cutoff. Let's have you start doing anything to address atrial fibrillation. I would say 6 to 12 months from now, we as a specialty look to see if at least we're paying more attention to atrial fibrillation when we're doing cabbages or mitral valves. What about prophylactic, LAAO? There's a question in the chat. These are all, I think it starts with awareness, and I think your workforce is doing a terrific job of just cataloging any attempt to address atrial fibrillation at the time of cardiac surgery. I bet you there'll be a Hawthorne effect. Now that we look at ourselves, we'll do a little bit more. And I hope in the next short term, so 2 to 3 years, your workforce will be able to better define what constitutes an AFib operation and at the same time be able to come up with measuring that as a true quality metric. So I say this with faith in our specialty. So I look forward to being right.
Well, Ram, I've learned long ago you're never wrong. So um, on that note, I want to thank the STS. I want to thank AtriCure for their support. I want to thank the panelists. And mostly, I also want to thank the 72 people who are still with us. I wish this was scheduled for more than an hour. I have a list of 15 questions. There's a few in the chat. If I can convince the panelists, we may try to put an FAQ together for some of these other questions. Please, you know how to, if you're on this webinar, you undoubtedly know how to contact the STS. Please reach out if you have comments about the quality metric. Again, this is meant to be really for your information to try to help bring awareness, brings it to the front of the report. You can see it. And our hope is that this will ultimately help our patients in a positive way. And thank you again for any of the data managers who I believe we sent this out to them. I think there's a number of you on the call. Thank you for all you do for the database. Without you, we would have no data and we would not have a database. So you are the key to what we do, and we really, really appreciate your time and dedication to this craft. With that, I think we'll say good night, and thank you again for joining us.
Thank you so much to our moderators and panelists for your participation and insight. We really appreciate all of your expertise tonight. If you're not one already, we do invite you to become a member of STS. You'll enjoy a variety of discounts and benefits and opportunities to help you grow professionally. Learn more at sts.org or scan the QR code on your screen. From surgeon trailblazers to the latest research and conference highlights, STS On Demand puts trusted, high-quality knowledge in the palm of your hand. Just press play. Subscribe now using the QR code. Register now for our upcoming Cabbage Academy meeting taking place this September in Chicago. The meeting will focus on skills development, collaborative learning for cardiothoracic surgeons and their team members. Again, please scan the QR code. We also have an STS perioperative and critical care meeting happening in Baltimore, Maryland in October. It'll focus on the latest techniques and management strategies in cardiovascular and thoracic critical care and enhanced recovery after surgery. Again, please scan the QR code. Lastly, we hope to see you in San Diego sorry about that. There is another webinar coming up on Saturday, August 8th, focused on the STS Asia webinar series, Surgical Management of Thoracic Trauma. And lastly, there is, I'm so sorry. There should be an STS 2027 slide up here. Go to sts.org and hope to see you in San Diego for the STS 2027 meeting. Have a great day, and we'll see you soon. Thank you again to everybody.
Thanks.
Bye-bye.